Hello everyone, my name is Dr. Hira Aslam and I am PGY3 at DMC Sinai Grace Hospital in Detroit, Michigan. Today I'm presenting a rare case of recurrent arterial thrombosis secondary to iron deficiency anemia. We all know that iron deficiency anemia is a leading cause of anemia all over the world. Iron deficiency can cause reactive thrombocytosis, which can then lead to thrombosis. Other causes of reactive thrombocytosis can include malignancy or infection. Iron deficient state is commonly associated with venous thromboembolism. However, arterial thrombosis secondary to reactive thrombocytosis is a rare entity. We present a rare case of recurrent arterial thrombosis secondary to iron deficiency anemia. Here we have a female 37-year-old with past medical history of fibroid uterus and iron deficiency anemia who presented with right upper quadrant abdominal pain and tenderness. Patient presented with similar complaints a year ago, at which time a CT scan of the abdomen was done, which showed 2.1 by 1.6 centimeter hypodense wedge-shaped area in the spleen, likely an infarct. Of note, patient had platelet count 544 into 10 to the power 9 and hemoglobin 7.8 grams at that time. Urinalysis was positive for UTI, which was treated with antibiotics. Splenic infarct was considered as an incidental finding and patient was discharged. This time when patient came in again with the similar complaints as well as chronic fatigue since past 1 year, her labs were done which showed hemoglobin of 4.0 grams and platelet count of 1173 into 10 to the power 9. Iron studies were done. Her iron level was found to be less than 10. Unsaturated iron binding capacity 674 and ferritin level 4.2. This established a diagnosis of severe iron deficiency anemia. Her peripheral blood smear, as we can see in figure 2, also showed microcytosis and hyperchromasia. Her platelet count was also increased on the peripheral blood smear. CT abdomen was done again on this admission, which showed thrombus along the wall of abdominal aorta projecting into the aortic lumen, as we can see in figure 3. CT also demonstrated wedge-shaped hypodensities in right kidney, evident in figure 4, which likely represented renal infarct secondary to thromboembolic phenomenon from intramural thrombus of suprarenal abdominal aorta. In order to rule out essential thrombocythemia to some extent, we did JAK2 V617F mutation, which was negative. Patient was treated with 81 milligrams of aspirin and 325 milligram ferrous sulfate daily. Patient has been following up regularly in ambulatory clinic and showing gradual improvement in symptoms and lab findings. Patient's last hemoglobin was 10.1 gram and platelet count 227 into 10 to the power 9. There have been no reports of further thrombotic complications. So this case report shows that iron deficient state causes differentiation and expansion of megakaryocyte progenitors, which can then lead to reactive thrombocytosis. There is a hypothesis that reactive thrombocytosis causes increased platelet coagulant activity, thus causing thrombosis. A population-based study done in 2015 showed that iron deficiency anemia is associated with increased risk of venous thromboembolism. There have also been a study which showed increased cerebral venous thrombosis in patients with iron deficiency anemia. However, a prospective study done on almost 1 million people in Denmark showed 1.8-fold risk of cerebral arterial thrombosis in patients with high platelet count. There also have been multiple reports on cases of stroke secondary to iron deficiency anemia and reactive thrombocytosis. In addition to stroke, reactive thrombocytosis secondary to iron deficiency anemia can also lead to peripheral vascular disease and gangrene. So, what we learned from this case report is that thrombus formation in absence of atherosclerotic plaque points towards thrombocytosis and increased platelet coagulant activity as a major risk factor for arterial thrombosis. And iron deficiency is a reversible risk factor for arterial thrombosis, in addition to being a risk factor for venous thromboembolism. So patients with anemia should be investigated for iron deficiency and should be treated in a timely manner to prevent the development of thrombotic complications, including infarcts, stroke, gangrene, and peripheral vascular disease. Thank you so much.